Good evening, all. Today we will discuss important aspects of transporting a critically ill patient. So, what we need to have some sort of protocol in terms of preparation, and if anything goes wrong, how we can troubleshoot. So, basically, we should not have some sort of major morbidity and mortality when we consider transporting critically ill patient, because when we transport a patient who is very bad, our intention is for some sort of reaching an unit where we can escalate the therapy, or we can do some more add-on intervention diagnostic modality. So our intention is going to be good. So we should not create some problem in terms of increasing mortality or morbidity when you consider transporting a critically ill patient. For that, we need a optimal preparation. So we'll try to go through all the aspects. So this topic looks very easy, but the problem is in some of the exams like European exams and all, so they might give some sort of scenarios. So they might ask in your edit part 2 and all. So like what modality of transport, what precaution, how you are going to prepare. So what documentation, what troubleshooting, these kind of questions you might get. So for that reason, we put this topic here. So basically, the background of transporting critically ill patients, we need to remember critically ill patients are in a dynamic and precarious physiological state. So transfer potentially exposes them to additional harm and instability because it is a totally uncontrolled environment. The goal of critical care transfer is to maintenance of high quality care. So during the process of transferring a patient, so moving the patient to an appropriate location in an expedient and safe manner. So this is the background when we consider transporting any critical ill patient. So this is some data which we published. So I was the principal investigator of this data which we published during my residency. We have done this study. So basically, to understand the complications and benefits of intra-hospital transfer of adult ICU patients. Remember, so what we are going to discuss today is inter-facility or inter-hospital transfer and all. So this data, what we published, suggest so transport of critically ill cancer patients is more hazardous and needs adequate pre-transport preparation. So transport in spite being hazardous may lead to beneficial change in therapy in a significant number of patients. So basically, this is the study done in patients who are oncological comorbid conditions, maybe hematolymphoid malignancy, solid organ malignancy, and all. So this data clearly suggests, though transport of patient intra-hospital, maybe for some procedure, some diagnostic modalities, some intervention from ICU to ward, or maybe ICU to means like operation theater, intervention radiology, or some sort of imaging modalities, it carries a risk, but with appropriate preparation, even the risk involved, we can reduce that risk and we are going to have a benefit in terms of some therapeutic advantage which improve the outcome of the patient. So basically, preparedness is very, very important. So this is one more subsequent data. So we done in pediatric intensive care patients, like benefits of and untoward events during intra-hospital transport. So again, critically ill children can be transported safely with adequate pre-transport preparation. So basically, I'm again stressing here. So it is the pre-transport preparation is very, very important, which may help in avoiding major untoward events and benefit the patient by change in therapy. Because when we consider transporting, as I told, it is for some therapeutic betterment or some diagnostic betterment. Okay. So in that way, it helps in overall outcome, but we need a proper preparation and all. So when it comes to transfer categories, we have something called care pathway, means where we want to transfer. So in terms of primary setup, secondary, tertiary, or quaternary like unit, maybe an intensive care unit. So whether we are transferring a patient like bed transfer, road transfer, or air transfer, so that is the mode of transfer of a patient. So urgency of care means emergency, urgent, or a routine, means sometimes like patient is having a like myocardial infarction, so in a primary center that is being identified with the ECG, or maybe based on clinical manifestation, so that becomes an urgent, means emergency indication to shift the patient for like some sort of revascularization therapy, like the stroke. Okay. Our patient is having some sort of sepsis, so drop in blood pressure, so you don't have modality for ventilator therapy and all, so that needs some sort of urgent transfer category of the patient. Routine means like, okay, so you admitted a patient and found incidentally there is a mass. So you need to evaluate further with maybe PET scan or other modalities of imaging. Biopsy is required. So that is the routine transfer category of the patient. So level of the care, so like we can have 0, 1, 2 or 3 or A, B, C, D depending upon the add-on like some sort of intervention what we are going to do when we transfer the patient. Indication, whether it is clinical indication or capacity indication in terms of the, again, the infrastructural additional need for that particular patient. Distance or duration, so it is intra-hospital transfer of a patient, so like inter-hospital, or it may be international. So sometimes we get a couple of patients through air ambulance from different countries for advanced therapy and all. That is the inter-hospital transfer. So we need to understand some of the common terminologies in transfer. So primary transfer from scene of injury or illness to the nearest receiving hospital, that we call it as a primary transfer. So extended primary transfer from the scene of injury or illness to a specialist center or trauma center, bypassing the nearest hospital to reach a center more appropriate to the needs of that particular patient, that we call it as a extended primary transfer. Secondary transfer from any hospital facility to another center. So maybe it is from emergency department, ward or ICU facility, or maybe OT of a particular hospital to hospital. So that we call it as a secondary transfer. Remember, primary is always from the scene of injury or the illness. So patient collapsed in the like summer environment, or patient had a road traffic accident. So we transfer from that incident site to an healthcare setup, that we call it as a primary transfer. Secondary transfer is hospital to hospital. It may be OT, ICU, ward, or maybe emergency department involved. So clinical transfer, transfer for specialty treatment or investigation not provided at referring hospital. So we don't have a facility for some sort of ECMO, we transfer the patient, or maybe advanced some sort of ventilator aspect, hemodynamic monitoring, we transfer the patient. That is a clinical transfer. So capacity transfer, transfer from specialist treatment or investigation normally provided at referring hospital, but which is not currently available. So there is some restriction. So we have some sort of MRI facility, but it is not functioning currently because of some logistic issue. So that is called as a capacity transfer. Very, very important. Transfer for capacity reasons may still be clinically necessary and are sometimes critical. So MRI needed, it is not functioning currently. So that we need to transfer the patient because it is clinically also needed during that particular time. Okay. So repatriation. So what exactly it means? Transferred back to referring hospital or a hospital nearer the patient's home address. Means we got some patient who had some sort of skin soft tissue infection for advanced skin flap surgery and all. So once we done some needful, so we transferred the patient back to a referring hospital, or maybe like once patient is bit in the recovery mode, we transfer the patient to home address. That we call it as repatriation. Inter-hospital transfer, transfer between the hospital. Intra-hospital transfer, transfer between areas, departments within the same hospital site. So these are some of the terminologies we need to understand. So transfer team. So what exactly involved in the transfer of a patient? Primary transfers, so ambulance services or emergency medical services are involved. Secondary transfer, so emergency or anesthetic or critical care doctors accompanied by a member of the nursing staff or a paramedical crew. So secondary transfer is from a healthcare setup to another healthcare setup. So that's why, so it is having involvement of all sort of like caregivers. But when it comes to say like primary transfers, it is from the site to an like institute or an hospital. So that is obviously road ambulance service, or maybe like a dial call based ambulance with emergency medical service we can get for the transfer facility. So 6 steps of transfer, so we need to understand. So identify the need for transfer of a particular patient, whether we are like transferring a patient for particular some sort of escalation of therapy that diagnostic modality is not available. Okay, so you don't have that equipment currently functioning. So whatever the reason, you need to identify why we are transferring a particular patient, or in Indian scenario it may be logistic issues like financial issue also. Agreement between referring and accepting senior clinicians is very, very important. So handover from critical care staff to transfer team. This should be very well documented, very well given handover, because patient was staying in an intensive care unit. So having some sort of multiple ups and downs, that should be clearly told to the transferring team so that they can have some sort of adequate preparation. Transfer between care facilities, that is the exact process of transfer. Handover from transfer team to accepting team, again it is very, very important. So return transfer team and equipment to the base, means we started from hospital A and we moved to hospital B, come back to hospital A, that is the return transfer team, with equipment handover to the base hospital. So these are the 6 steps involved in the overall process of the transfer. So what are the risks involved? So we need to understand the risk has been categorized into technical risk. Either it may be like patient having an impact, or it may be because of the some sort of equipment failure, or non-technical risk factors like in relation to manpower. So that is crew involved, resource management and all. So or it may be organizational risk of the transfer, which is like governance related risk impact because of the transfer. So when you see the data, so major physiological derangement happened in about 15% of the patients who undergone transfer. So patient are relative dissatisfaction, maybe clinical deterioration happened or some equipment failure happened during the transfer. So that leads to dissatisfaction of the patient are relative in about 7% of the patients. Prolonged hospital stay while transferring a patient, clinical physiological derangement because of some fluctuations in the vital, that leads to an add-on stay in the hospital, that happened in about 4% of the patient. Physical or psychological injury in about 3%, mortality is around 2%. So these events are underreported. So basically some of the institutes like where we have some sort of transferring a patient, so we might not have a very good data to get an idea. So how much is the percentage of incidents, particularly in Indian scenario? So they might not disclose what exactly happened during the transfer of a patient, whether it is an equipment failure or oxygen non-availability or exhausting oxygen source, or some sort of broken instrument, or maybe medication error, medication non-availability. So we have multiple reasons, but it is underreported in many of the developing countries and all. So yes, we can prevent these risks involved with the transfer of a patient with a greater extent with proper like preparation and all. So it is a preventable to a great extent. So that is like what we need to understand. Outcomes can be improved and adverse incidents can be reduced. Careful patient selection. Patient is on PEEP of 12, okay, 100% FiO2. So like is on 20 ml of norepinephrine. So not an appropriate patient when it comes to risk involved in the transfer of patient and all. So transfer planning is very, very important. Equipment preparation, okay. About 50 to 90% of the transfer incidents are preventable. So according to a published data from UK. So very, very important. It's a preventable risk associated process, that is the transfer. So like we need to understand some sort of the core concepts to be insisted always when it comes to transferring a patient. So maintain monitoring and physiological targets, whether whatever the heart rate we want to achieve, so whatever the urine output you want to achieve, temperature control, blood pressure. So all these things we need to achieve during the transfer process also. So competent team should provide care in an expedient manner. So very important. Don't think, okay, patient is already on ventilator, so we don't require any doctor who is trained in airway management and all. There might be accidental extubation also. So team should be competent to manage the complication. So organizing transfer services should ensure the safety of the staff who are involved. Maybe patient is like some sort of having a, assume during COVID and all, we should have a proper personal protective equipment. Okay, so all these things are very, very important. At most as equivalent to that of the patient safety also. So staff safety is also very important. Transfer should not be undertaken unless the risk of continuing care in the patient's current location are greater than the potential benefits of the transfer. So when you consider transferring a patient, so other than some financial things involved, so there should be an add-on benefit. So when you transfer a patient, means like either in terms of therapeutic or diagnostic modalities. Okay, it should add to overall improvement in the morbidity and mortality, overall benefit when you consider such a high risk like task, that is the transfer process. So we'll go one by one the risk involved, that is the technical risk during the transfer. So this is maybe related to equipment failure. So two major issues in transfers is inadequate or unreliable power supply. Okay, particularly monitoring system, battery, or maybe infusion pump. Okay, or maybe transport ventilator or NIV machine battery power, or it may be a problem with that of the oxygen source. Means you might not have checked properly, or there might be malfunctioning monitoring gauge of a oxygen cylinder and all, that may lead to some sort of the major equipment failure. So basically different from hospital equipment. So that is one reason, because we have a ventilator in the ICU which is entirely different than that of like transport ventilator. So they are not an sometimes may not be a high flow ventilator and all. We might not able to give 100% oxygen through the transport ventilator. Unfamiliar environment, so missing equipments. You have not done a thorough checklist evaluation before initiating the transfer, or damage to a equipment. Means like there might be sometimes like disconnection, damage to oxygen cylinder hose, or maybe piping system. So all these things can happen. Incompatible means we have some issues with the like wiring incompatibility or adapter incompatibility for a particular monitoring device are out of date. Means it is not in the range of like expiry date, particularly medications and all. So these are like lead to the overall failure of the transfer, or like some sort of equipments also like out of date in terms of their functional capacity and all. How to overcome it? So assign a dedicated equipment. Okay, so this is the transport ventilator, will not touch for any other purpose. Okay, this is the cylinder, always check it is filled and you keep it dedicatedly separate. So transfer platform must be appropriate. So like whether we are going through road, or it may be like bed transfer, or it may be air transfer, that platform should be appropriate for that particular patient. Means suppose you are planning to travel 1,000 kilometers, then it may not be an appropriate to transfer the patient by a platform that is road transfer. So then obviously you are going to have a lots of mishap in terms of technical failure and all. So inside for both patient and transfer team, so we need an appropriate platform. Outside for the environment, it is likely to encounter. Means whether we are transferring a patient through a hilly region, or a road is not appropriate, okay, or through the village. So all those things you have to be very well planned in terms of the route selection and all. So before transfer, route should be agreed, okay, among the like transfer team and the referring hospital and the receiving area and all. So emergency strategies should be discussed. Suppose you are transferring a patient on an ambulance. So what like is the plan B if anything happens while transferring a patient? Means are you going to shift the patient again to a nearby hospital on the way? So are you are going to have some sort of any sort of like other alternative plans when an emergency arises? That should be discussed and should have some sort of plan B available. So transfer risks which are non-technical associated. So small teams working in isolation, that is one of the reason. Means like we don't have a huge team when we involved in the transfer of a patient and all. Maybe we have a one paramedical staff and maximum one doctor available. We don't have like some sort of major expertise sometimes in the process of transfer. So that is one like cause for the risk associated with the transfer and all. So teams are often unfamiliar with each other and the patient. So particularly, so one team is managing the patient in intensive care unit. When you means like consider for transferring, you are giving an handover to a different team. So they are entirely unfamiliar with that particular patient's dynamicity in the ICU and all. So communication and liaison between ICU and sites of destination or origin is very, very important. So we should give a proper communication like in an appropriate way, the entire thing about the patient. So otherwise it may increase the risk involved with the transfer. So transfer risk, which are organizational, as I already told, which is like related to governance process and all. So transfer causes burdens on both preparing and remaining staff. So because obviously one team is preparing, so the whole process of the transfer and all, one team is assisting in preparation, means like, so patient is managed in ICU, they need to give the handover, they need to arrange some of the like lacunae in the transfer team and all. So all those things will put a burden in both the teams and all. Transfer must not jeopardize other patients or work within the hospital. Means one VIP patient you have, you're planning to transfer that particular patient, which should not create problem in terms of giving the care to other patients who are in the ICU. Admission and transfer delay are independently associated with ICU morbidity and mortality and must be kept to a minimum. So these are some of the organizational risk involved. Add on to that, accompanying staff must be safely and promptly returned to their base after the transfer, like including the equipment and the staff. Without any problem, they should come back. So late finishes need to be acknowledged with a rest times observed, because the transfer may happen in the night hours also. So when they traveled throughout the night, again when they return back in the daytime, they should get an adequate extra off for their whatever the effort they put. A dedicated transfer service has many advantages and is the preferred method of transferring patients requiring specialist treatment or who require prolonged transport. Means in any tertiary care center, so it is obviously there, like we have some sort of dedicated, so like transfer team available, so who are involved in transferring the patient inter hospital always. Okay, how to reduce the transfer related incidents? So simple rechecking of equipment, recheck patient before transfer, appropriate use of protocols during transfer, pre departure checklist should be routinely used. So complete all necessary preparations. If recording patient information, the normal Caldecott and confidentiality rules are applied. So the Caldecott principle is basically maintaining the anyone's autonomy, anyone's confidentiality. So that we call it as a Caldecott principle. There are many like factors, many components in the Caldecott principle. One principle is maintaining confidentiality of the patient. Okay, so when it comes to procedures and protocols involved, so decision making is very important. So the decision to transfer must be made by a senior doctor who involved in the giving care to particular patient, so preferably a specialist or a consultant in charge of that particular patient. After weighing the risk and benefit, then only you need to make a decision for transferring that particular patient. So decision must be communicated to the next of kin where applicable. Means if patient is on ventilator under sedation, obviously we are going to discuss with the immediate family, so the pros and cons, and we are going to come to a single consensus. Communication should not supersede or compromise the clinical management of that particular patient. Means like, okay, so we are in and around discussing transferring a patient. It doesn't mean okay, any of patient will go out of the hospital, will compromise the care, or we make the care very superficial. That should not happen. Okay, that is very important in terms of avoiding the risk involved during the transfer of the patient. So initiation and response, each facility must have its own mechanism of patient transport system. The initiation of patient transport system should be simple with clear guidelines. The response of the transport system should be rapid. When you consider, do all the checklist, prepare the patient, and it should be rapid, because so sometimes that helps in saving a particular organ system. So like in myocardial infarction, okay, we know that, so time is the muscle, time is the tissue, time is the brain. So we need to be a bit rapid in terms of transferring a particular patient. So coordination and communication must be reliable and available at all times. Communication loop must be established among the referring facility, transport team, and that of the receiving facility. Means, so the team who is referring should give a message to the receiving facility, the probable time of reaching that particular hospital, the clinical condition of a particular patient, what the receiving facility should be ready with. So they might need to arrange a operation theater immediately. The patient needs some sort of intervention, radiology, or some sort of intervention, neurological procedures and all. So that need to be clearly communicated to the receiving facility also. So again, first contact communication between a referring and receiving facility should include the following. As I already told, patient's current condition and what management we have done in the particular hospital. Steps needed to be taken in planning and preparation for the transport also we need to communicate. So responsibility, when it comes to responsibility, the chain of responsibility must be clear throughout the transport. So delegacy of the work. Okay, you take care of the airway, you take care of the infusion pumps. In ECMO and also, who is going to do like what work should be appropriately delegated? Who will take care of the lines? Okay, without any some sort of dislodgement. If patient is having a drain, who will look into the drain? All those things should be clearly delegated in terms of the responsibility. The most qualified medical practitioner should be responsible for the entire transfer process. Pre-transport resuscitation and stabilization is a joint responsibility of both referring and receiving facility. Agreement between referring and receiving facilities must be achieved on the emergency care and level of stability prior to commencement of the transport. Okay, before initiating the process, so everything should be sorted out with the bi-directional single consensus communication between transferring like unit, that is the referring team, and that of the receiving team. So care of the patients and safety during transport is a responsibility of the referring facility. Means the point from where a patient is started. So we need to have some sort of hold, like what need to be done during the process of transfer also. Upon arrival, the continuity of the care is the responsibility of the receiving facility after completion of the handover. Handover should be done between medical personnel of the same or higher level. So it's not like, okay, so an intensivist accompanied the patient and you are giving like some sort of handover to nursing staff. That should not happen. Either to an intensivist or maybe intensivist to maybe head of the department or whoever is in the higher hierarchy. We should consider giving appropriate handover. That is very, very important. So documentation, the clinical record should have the following documentation: patient's clinical status before, during, and after transport, relevant medical conditions, therapy given in the referring hospital and during the transfer, any other patient events or conditions which happened during the transfer process. A copy of this record should be provided to the receiving facility. So staffing involved in the transfer process, the transport team should be selected based on the clinical requirements of that particular patient. Okay, suppose patient is having a ECMO in situ, we need a perfusion team to be accompanied. So preferably one surgical background is also necessary. Okay, patient is on ventilator, so definitely we need a respiratory therapist and an anesthetist or an intensivist is needed. So clinical requirement is the main thing to decide on which staff is going to accompany that particular patient. So this includes the capability to monitor and provide emergency or pharmacological intervention for that particular patient. Particularly, we need to be trained in ACLS. Okay, so when it needed, we need to give cardiopulmonary resuscitation, airway control, administering medication. So all these things are like included when we choose a particular staff. There should be a minimum of 2 transport team members at the patient compartment of the transport vehicle for the purpose of monitoring and intervention. Means it's not one is with the patient, one is driving. It should not happen. At least 2 person should be in the compartment of the ambulance, not in the beside the driver seat and all. Okay, so there should be at least one member of the transport team who is trying to initiate emergency intervention, including airway management. So depending upon the clinical requirement of the patient, a doctor who is trained in the management of a critically ill patient may be required to be a member of the transport of team. So sometimes paramedical staff is okay if patient is moderately sick, but if patient is sick in a severe category, we need a proper trained doctor to address the emergency, which may have some sort of sequelae during transfer process and all. Okay, if such a person is not available, then an online medical directive approach is needed. Suppose you don't have a doctor to accompany. Okay, you initiated the transfer process with a paramedical staff, but you should be available on call. So online medical directions are directives given for particular patient care by a physician who is not physically present at the patient's side. Okay, so training, each facility is expected to conduct training with regards to following key areas: usage of equipments which we use during the transfer process, effective medical communication. Okay, suppose you are telling, so give some sort of increase the vasopressor dosage, so that receiving person should be able to understand what exactly the vasopressor agents and all. That medical communication understanding is very, very important. That should be involved in the training process. Emergency care for critically ill patient. safety of the transport means like you should not get infected when you are handling a patient with highly infected respiratory tract infection. And also safety equipment and the staff safety is very, very important in the training process. Mode of transportation consideration. Mode of transportation to be used will depend on the following factors like nature of the illness, so possible clinical impact of the transport environment, urgency of intervention, and location of the patient. Means like patient had some sort of event in the sea area, so then the mode of transport is going to be sea route. Means like, so basically where the incident happened. So depending in a forest area, we might not able to move through the road, so we might require to airlift in a from an hilly area. And also the mode of transport also depend upon the location of the insult which created to a particular patient and all. Okay. So distance involved, so number of accompanying personnel and equipment involved, so road transport time and road condition. So all these things we need to consider with the range and speed of vehicles involved in the transfer when it comes so to choosing a mode of transportation. Okay. So mode of transportation, so additional things like fundamentals for all safe modes of transport include stabilization of the vital signs, provision of a secure airway and IV access, so securing all the catheters, drains, okay, pipes, provision of appropriate monitoring. The vehicle must be equipped with the minimum equipment required. So unnecessary equipment is not needed, saying that the necessary equipment should not be missed in that particular vehicle. So transport vehicle requirements are vehicle should be well maintained and regularly serviced. So the vehicle must support the use of equipment such as adequate power supply. Means you should have a battery backup from the vehicle which you are using for the transferring purpose and all, which may be like some sort of involved with the national ambulance code, and it should satisfy some sort of the prerequisite criteria which are described by national ambulance code in terms of design, equipment. Okay. So standardized process which involved when we choose a particular transport vehicle. Okay. Medical transfer equipment. So what proper equipment we need? So particularly airway, breathing and circulation management equipment, including infusion pump. Okay. So CPR associated drugs we need. So different size endotracheal tube. Okay. Ambu bag. So medications including sodium bicarbonate. Okay. Atropine, adrenaline, norepinephrine, dobutamine. Okay. So or maybe some other medications including antibiotics, because transfer if it takes more than a couple of hours, more than 4 hours, 6 hours, you need to give antibiotics 6 hourly, 8 hourly. So all those medications should be available. Electric devices, trolley, oxygen cylinder. So all these things are the basic like equipment requirement for transporting a patient. So this is again comprise the different side headings which are necessary for transferring a particular patient. Airway breathing, like suction equipment, stethoscope, face mask, airway, self-inflating bag with reservoir, gum elastic bougie, tracheal tubes, connectors, ties, tracheostomy tubes if needed, if appropriate, laryngoscope, different sizes of the blade, spare batteries, that cells are very, very essential, circulation, IV cannula, IV dressing, tape, okay, syringes, needles, IV fluid, and a particular given set, mini sharp, receptacle, so should be available. Resuscitation drugs like including adenosine, hydrocortisone, epinephrine, lidocaine, amiodarone, metoprolol, atropine, naloxone, so calcium chloride, norepinephrine, lorazepam, like particularly for treating the convulsions, salbutamol nebulizer, glucose, that is the dextrose, sodium bicarbonate, furosemide, saline ampules, GTN spray, like plain drug labels, means like without any filled like empty drug labels, because there should not be any error while administering the particular drug. We need to label it appropriately. Sedation and muscle relaxant, propofol, midazolam, dexamethasone, atracurium, vicuronium, rocuronium. So pediatric equipment, if required, if you are involved in transferring a pediatric patient, that should be thoroughly equipped in that particular ambulance. Okay, how to select the equipment? Equipment should be appropriate for use according to the following factor: patient condition. So if patient is too sick, so then we need a multiple infusion pumps and all. So level of monitoring needed during transport means, are we going to monitor the invasive blood pressure, non-invasive blood pressure? So okay, so depending, or you are requiring some sort of ICP monitoring during the transfer. So depending upon the monitoring during the transfer, the equipment you are going to choose. Level of therapeutic intervention required means, are we going to just continue some sort of like particular vasopressor, or we need some more inotropes also. So depending upon that, we are going to choose the equipments and the infusion pumps appropriately. How to select equipment? Again, attention must be given to size, weight, battery life, oxygen consumption and durability, as well as to suitability for operation under conditions of the transport. Electrical and gas supply fittings of all equipment must be compatible with the transport vehicle. Very, very important. Means, so if it is not compatible, it is useless during the transport process. All equipment should be properly calibrated, so maintained and regularly checked. All equipment should be incorporate audible and like visual alarms, because so sometimes that is lacking during the transport process. If alarm system is not functioning, then you are not able to identify the trouble. If you don't identify the trouble, so you are not able to troubleshoot that particular incident. Okay, so equipment handling during the transport process, all equipment should be adequately restrained and readily available to the operator. So monitoring and infusion devices should be kept in areas visible to the accompanying staff to identify the vitals and their fluctuations and all. Patient stretchers should be adequately secured within the transport vehicle. So when it comes to emergency drugs, so which include all vasopressor, sedatives and neuromuscular blockade medications, as I already told. So any stock medications, including fluids and blood products, if appropriate in a trauma patient, that may be necessary, should be taken on the transfer with the required diluting solution, labels, lines, and that of the pump. Sometimes, so blood arranged, but we don't want to wait till we transfuse the blood. You can initiate and take that blood bag, and we can consider transferring a particular patient. Okay, so stock medication can be kept in an easily transportable bag and should be regularly checked. Specific drug doses calculated before the transfer in relation to their particular weight. So specifically with specific high risk agents like neurosurgical and pediatric patients, we need to calculate the appropriate dosage and all. So if required, some medications which need some sort of refrigeration, so we need to consider fridge and high risk medication for transport process and all. Okay, so again, this is the overall checklist for preparation in relation to airway, breathing, okay, circulation, so disability assessment during transfer process and all. So temperature control is very, very important. Anything forgotten, like some sort of preparation, you need to have some sort of thorough checklist. So when we prepare for transferring a patient. Okay, monitoring during transport, constant direct observation of patient by medical personnel is essential during the transfer. So it includes continuous cardiac rhythm, that is like whether patient is having a sinus tachycardia, sinus bradycardia, non-invasive blood pressure or invasive blood pressure, heart rate, respiratory rate, oxygen saturation. These are the basic monitoring during the transport. So end-tidal CO2, it is recommended especially for transporting intubated patients with a head injury or raised intracranial pressure. So documentation of monitoring is recommended at 15-minute interval or shorter when clinically appropriate. So like monitoring and documentation both are very, very important. So pre-departure procedure, transport team must be free from other duties upon activation. Means you are initiating a transfer process and the team member gone for some more delegated work. That should not happen. So you should have a dedicated team. The receiving person or a staff at the destination must be notified and the arrival time must be clearly understood. All pieces of equipment must be checked and notes and imaging films are gathered from the referring center using a checklist method. So individual responsible for checking equipment must be identified. So this is the person A, he checks all the checklist that appropriately identified. A best route should be planned. So lifts should be secured or reserved beforehand when we consider transferring a sicker patient and all. So PEG saturation probes can be temperamental. So these are the PEG saturation, like oxygen saturation monitoring gadgets. These are not reliable. There is a chance of like recurrent dislodgement and all. Consider either ear or single-use adhesive probes. Like these kind of saturation probes are appropriate. So pneumothorax should be identified before transferring a patient, decompressed and drained before transfer. Bag wall mask are essential in case of gas or ventilator failure. That is, ambu bag is very, very essential. Functional ambu bag you need to carry during transferring a patient. So like oxygen requirement should be calculated before transfer. Remember, so it should be twice the patient consumption plus ventilator consumption. That should be the available oxygen resource, oxygen source when you consider transferring a particular patient. Means double the requirement should be there. If needed one cylinder for the entire process, you should have a two cylinder. That is very, very important. We need to understand different uh, cylinder types and whether it may be having a pin index type or bull nose type of their top part of the cylinder, so which is the hose of the particular cylinder. Either it may be pin index type or bull nose type. See, these are the oxygen cylinders and their capacities and pressure. So we have B, D, E, F, G, H, M. So capacity is 200, 400, 660, so on. So like up to B, D, G, these are the wall type is going to be pin index based. Like bigger cylinders, F, G, H, M. So they are having a bull nose type of the wall type. So we need to understand their like total weight also, the pressure in a particular cylinder type, that we need to have some sort of idea when you consider transferring a particular patient and all. So one important thing is how to calculate the available oxygen in a particular cylinder. Okay. So service capacity in liters divided by service pressure in pounds per square inch, that is PSI, is equal to volume remaining in liter divided by gauge pressure in PSI. Gauge pressure is what we get in the monitoring of that particular gauge of a particular cylinder. So if service capacity is 660 ml, that is for E type of cylinder. E type of cylinder capacity is 660 liter, pressure is 1900. Okay. So here like service pressure is 1900 psi. So like service capacity divided by service pressure, that equal to 0.35. So 0.35 into gauge pressure is the per liter per minute to be delivered. That equals to duration of oxygen flow in minute. Okay. So example, if E type cylinder we are using, gauge pressure means the service pressure total it is 1900, but whatever the gauge which is showing, which is measuring, is around 1500. Flow required, you kept a particular patient 15 liter per minute of the oxygen flow. So then the amount of oxygen sufficient for particular time, that time is equal to like 0.35. So that is service capacity divided by service pressure, that comes 0.35 into gauge pressure, that is 1500, divided by, okay, so how much we are delivering per minute, that is 15 liter. So that particular cylinder is going to be sufficient for another 35 minutes. This is how we are going to calculate. Very, very important. So you might get some questions based on this. So worth remembering some of these basic formulas when it comes to calculate the available oxygen in a particular cylinder and how much duration that will be sufficient for particular like flow which we kept. So this is again one more method, calculating oxygen reservoir. So that is operation time in minutes for different minute volumes if you are giving 100% FiO2. So if you are using a D type cylinder which is having 340 liter capacity, so 5 liter per minute, okay, minute volume is equal to 56 minute. Minute volume, if you are considering 7 liters per minute, it's going to be around 42 minutes. So minute volume, that is 10 liters per minute, if you are giving, it's going to be 30 minutes time duration. So basically you are giving 100% FiO2, but if you give 10 liters per minute, so only 30 minutes this D type cylinder is going to work. If you are using E type, so then if you are giving 100% FiO2, so it is available for 60 minutes. If you are using F type, if you are giving 5 liters per minute with 100% FiO2, 226 minutes we can use, which is having a capacity of around 1360 liters of oxygen. So this is one again thing you can remember when you are transferring a particular patient. So patient packaging and loading, this also very, very important, particularly head injury patient, pregnant patient, so multiple unfixed fracture patients and all. Patient must be reassessed at all steps of movement after transfer to stretcher, loading into ambulance before transport begins. Follow checklist quickly. Upon satisfactory evaluation, only then should be actual journey should be initiated. Okay. So what is the quick assessment of the checklist? So these are the like areas: airway, ensure secured and it is patent, do adequate suctioning, breathing and ventilation, adequate respiratory variable, appropriate PEEP or CPAP, FiO2 levels are like correctly chosen for particular clinical scenario. Circulation should be hemodynamically stable. Vital signs are displayed on transport monitor and clearly visible to the transfer team. So venous access, it is adequate, secured and patent. So IV drips and infusion pumps functioning properly with appropriate battery backup. So all drains, urinary, wound are underwater seal functioning properly and they are secured properly. Underwater seal drain is not clamped, should not be clamped during transfer process. Very, very important. That is for pneumothorax and all. All equipment alarms are switched on. So just alarm is going to bothering, don't switch it off because we will miss many of the fluctuation during the transfer process and all. Patient should be safely secured on the trolley. Okay. So care during the transport, status of the patient must be checked and at regular intervals. Act immediately for any change in patient's condition, unexpected event, or any critical incident. So you should act immediately in terms of good resuscitation approach. So arrival procedure. So the patient will need to be received at a designated area where handover of clinical care can be done. Maybe in the emergency department or directly to operation theater or maybe intensive care unit, not in the ward area or may not be in the like corridor and all. Very, very important. The transport staff must remain within the patient until an appropriate handover has been done. So it's not you just dump the patient and you just walk out from there. It's not acceptable. So transfer of trauma patient, we need to understand cervical spine immobilization is very, very important. Pelvic and long bone fracture immobilization, all drains and lines should be secured with a fixed in a particular place. So inter-hospital transfer on spinal board or scoop stretcher is inappropriate. So these are only for taking the patient into a trolley, but should not consider transferring the patient from hospital to hospital either on a spinal board or scoop stretcher. Okay, these are only for emergency purpose. So prevent hypothermia in trauma patient during transfer. Ensure that uncovering of patient is limited. So because hypothermia, acidosis, coagulopathy will initiate the triad of death. So prevent heat loss and preserve heat like using vacuum mattresses, blankets, bubble wrap. So active warming, all these things are very, very important. Continuous temperature monitoring is recommended. So packaging of particular patient. Okay, so how we need to fix that particular patient? Careful packaging should minimize movement, particularly head injury patients and all. Minimize the heat loss, minimize snagging and injury during the transfer. So creases and other clinical debris in the sheet should be avoided to reduce pressure areas. So if the sheet on which the patient is lying, if it is having a too much of crease, which may give some sort of like pressure injuries during the process of transfer if it is involving too much duration for the transfer process. So transfer trolleys must fit securely into the vehicle to protect the patient and transfer team in case of an accident. That we need to remember. In an untoward like some sort of incident, patient should not move too much, so you need to fix him properly. So in particular special situation like disaster scenario may be difficult to follow the proper standard. So because it is an emergent procedure, so we might not have a thorough like maintaining a proper standard and all. Patient on circulatory supportive devices, we need a like specific arrangement, particularly if patient is on IABP, ECMO. Specialized devices like incubator, temperature regulation devices should be taken care with a special precaution when the special situation arises. Okay, so devices should have adequate battery power. So So inappropriate setting, including alarm limit, if anything involved, fully operational before and during the transport. There should be a trained personnel who are able to provide the specialized care, particularly when we are transferring patient with IABP or ECMO. So a particular trained personnel is very, very essential. So care of the transport team. So this is the staff care, means who are involved in the transporting particular patient. Personal protective equipment, warm clothing, ideally high visibility jackets should be worn, like these kind of jackets, so that like we are able to see appropriately, identify appropriately. Theater scrubs are not appropriate. These are for the routine on the board usage. They are not like appropriate when we consider transporting a particular patient with a transport team. We need a high visibility jackets, like these kind of jackets. Okay, yeah, there should be a mobile phone with a transport team, and money for like food and the expenditure involved during the return journey, that should be appropriately taken care. Many clinicians suffer from motion sickness, and this should be addressed, and they should have an adequate insurance coverage, because if any untoward effect happened during transferring a patient, if any accident happened, there should be adequate insurance coverage for the transport team also. Very, very important. Okay, so these are some of the data. So this is NHTSA like data. So on ambulance crash, so means some sort of the accidents which involved with the ambulance, according to the data, so which is collected from National Highway Traffic Safety Administration. So in between 92 to 2011, this is the old data, there was an estimated annual average of 4,500 vehicle crashes that involved ambulances. Okay, so of these, 34% resulted in injury, 33 people were killed. Almost 60% of the crashes occurred while the ambulances were in the emergency use, because there is an urgent process of transferring. So all these mishaps happened. So again, if you see this data, 84% of emergency medical service providers in the patient compartment were not restrained. They are not wearing the seat belt. Okay, so that is the reason to have some sort of untoward effect or the impact when a patient, means when an ambulance had a crash. So again, only 33% of patients were secured with shoulder and lap restrainment, like this. So that is the reason for having some sort of, again, some more add-on bad impact because of the ambulance crash. But in India, we don't have a very good scientific data available. So no available scientific data on ambulance crashes. Only in India we have newspaper report, like Mumbai, some reported women losses fetus in ambulance crash. So like 10 killed as air ambulance crashes in Faridabad. So this kind of like some sort of newspaper data we are having, but we don't have some sort of scientific data, because as we know, there are some reports are underreported when it comes to even ambulance crash also. So a little bit on the air transfer, the equipment and constraints of air transfer vary depending upon platform and provider. Only clinicians confident and competent in aeromedical transfer should be undertake air transfer. So clinical team should position themselves safely to enable observation and access to the patient and any ancillary equipment. So like monitoring, ventilator, syringe, pumps and all. So nowadays, like air ambulance are available commercially. So like involved in transferring a patients who are on ECMO also, but we need a specific like some sort of preparedness when we consider ECMO transfer through the air ambulance and all. Okay, so transfer decision making algorithm. If you see, this is the decision making algorithm. Very, very important. Very simple to understand also. So assess patient condition. Is patient stable? If answer is no, provide resuscitation and other measures as indicated, and to degree possible, like secure the airway, IV access, fluid resuscitation, do basic appropriate imaging including lab and X-ray evaluation. Okay, or if patient is stable enough to be shifted, transferred, so assess need for transfer. Again, you need to question, are we going to get benefit by transferring a patient? Are the resources at current facilities adequate to address the patient needs? If answer is yes, continue managing the patient in the referring unit, don't transfer the patient. If the answer is no, okay, so then like compare benefits and the risks of transfer. This patient is candidate for transfer after assessing the risk and benefit. If answer is no, continue again the current management plan. If the benefit is more than that of the risk and patient is a candidate for transfer, if the answer is yes, select receiving facility. means to which area we are going to transfer, like its distance. So what resources available in the receiving end, bed availability, very, very important. So patient preferences means family might require, okay, we don't want to a particular hospital, we want a particular hospital, that we need to consider. Identify and communicate with the receiving physician. Has transfer been accepted? Means after evaluating all these things, so the accepting team tells, okay, a green signal to get the patient into their unit. If the answer is no, so then again, still we need to continue the care in the existing unit only. If answer is yes, then obtain an informed consent and notify the family member involved. So select the mode of transport, means ground or air transport, cost involved, patient acuity, distance involved, weather condition, all these things we need to analyze. Mobilize necessary personnel, transfer equipment and the medication involved. Nurse to nurse report to receiving facility. Okay. So copy medical record for receiving facility. If everything is ready, initiate the transport. Patient sedation as needed. So restrain as needed. Medical record keeping during the transport, including documentation. Follow the protocols. Communicate with medical command as needed. Okay. When completed, evaluate transfer for quality improvement. Means what went wrong. So whether it was a technical failure, manpower failure, medication error, what happened, and what is the reason for some untoward event during the transfer. So you need to evaluate that so that we can have an upgraded quality improvement from the entire process. To summarize, medical transport of critically ill patient involve various level of risk, challenges and morbidity or mortality. Meticulous planning, checking and rechecking are the essential components of safe transfers. Well-placed process and protocols and its strict implementations are mandatory for a SL-free medical transport. Dedicated transport team and their well-oiled teamwork are mandatory practices. Documentation, handovers, and effective communications are to be followed strictly. Follow the checklist system always whenever appropriate. So thank you.